Olá, colegas, sejam bem-vindos a mais um evento da GSK Brasil, ao highlights do Congresso da ATS 2017. Hoje nós vamos discutir os pontos mais importantes que nós visualizamos aqui durante o Congresso. Eu sou Oliver Nascimento, sou médico da disciplina de Pneumologia da Escola Paulista de Medicina da Universidade Federal de São Paulo e especialista interno da GSK Brasil, e conto com a presença do Bernardo Maranhão, que é professor da Universidade Federal do Estado do Rio de Janeiro e também especialista interno da GSK Brasil. O Marcelo Tadai Rodrigues, que é professor da Universidade de Santa Cruz do Sul, né, da disciplina de Pneumologia de Santa Cruz do Sul, e também especialista interno da GSK Brasil. E contamos com a presença de dois ilustres participantes, que são Global Medical Expert da GSK, da franquia respiratória, que é o Dr. Emílio Pizzichini, que também é professor da Universidade Federal de Santa Catarina, e o Dr. Paul Jones, que é professor de Medicina Respiratória da Universidade de St. George de London. So, thank you for being with us, Dr. Paul, Dr. Emílio, and to discuss about the ATS Congress. There was a lot of discussion about COPD, asthma, and other diseases that we'll discuss now. But, Dr. Paul, what did you say to us about COPD? Because there is a lot of sessions about mild and, let's say, about early disease in COPD patients. What's your point of view? What did you see to talk to us now?
Yes, one of the things, in the past we've tended to mix the two together. Early disease and mild disease are the same thing because we always used to think that COPD is always a progressive disease. But I think it's become very clear that we should differentiate mild disease and early disease. And you can be in 60s and 70s and have mild disease, which is clearly not going to be progressive. But if you have early disease and you're 50 years old, that may very well be progressive. So they are not only probably two different phenotypes within COPD, they also should alter our approach to treatment. So I think that simple clarification is a significant step forward.
Yeah, and what point of view of you about the screening in COPD patients to identify these patients? Marcelo, I don't know if you want to tell about that.
One of the topics of the year in review in COPD was the US task force recommendations about screening or not asymptomatic patients for COPD. And the recommendation is not to do it because there are a lack of evidence if it's worth or not. And also, they don't know exactly if the patients are really asymptomatic or no, because we know patients with COPD, early COPD, they reduce their activities to not feel breathlessness. What do you think about it, Dr. Emílio?
Well, I think one of the recommendation of the U.S. task force, I think is correct. We don't need to look for a disease in patients that do not have symptoms. However, population-based studies done in Brazil and other countries have stressed that if you do a very specific questionnaire, you are going to find patients with symptoms. And in those patients, screening is very important. And then you can use either one of the instruments that they have recommended, and physicians are very good at assessing symptoms. And this should be done not only by respiratory physician, but overall for any kind of physician that see patients in overall practice.
One of the things that's come out of both the spiromics and the COPD gene studies is that there are smokers who have, if they have symptoms, it's clear they've got airways disease. They may not have airflow limitation, but they've got airway wall thickness, they have more exacerbation-like events, their health status scores are worse, and they probably need treatment. So as Emilio said, symptoms are the important marker, and if they have symptoms, then we need to use case-finding techniques to identify those who need spirometry.
And then that's the question about how we define COPD. Because the definition, it's spirometric, it's the reduced FEV1, FVC ratio. And there are patients who have chronic bronchitis and emphysema, but they don't meet the criteria for COPD.
Yeah, this patient they have an alteration in the CT scan and tomography and the diffusion. And what do you think about this? Is another phenotype, or what is the importance of these patients?
Yeah, every ATS there's a new phenotype, isn't there? I think, but it is becoming clearer. There is the phenotype we've just talked about with preserved airflow, but airway wall thickening. There was a very interesting presentation about analysis from COPD gene showing, taking into account CT scans and clinical factors, that there are 3 distinct groups of patients: those who are airway wall predominant, those who've got emphysema predominant, and those who have both. And the prognosis of these patients is different too. We also know that 10% of patients have got pulmonary infiltrates, COPD patients with pulmonary infiltrates, and we're beginning to know that that also is associated with a poor outcome. So we're all the time building up different phenotypes. And the important thing is that we can now maybe identify those phenotypes and then study them more specifically.
If I may add here something, it's also important to stress that for respirologists, for pneumologists, it's important that when we have a patient that has symptoms, we need to use the armamentarium that we have, because the reliability of those instruments has increased, and now they give us information that's very important to characterize better a patient and then decide about the best treatment approach for those.
And for patients with, I'm sorry, Bernardo.
No problem.
And for patients who has symptoms, are smokers, and if the patient has a normal spirometry, what exams do you prefer to perform these patients? Only CT scans or lung diffusion?
I would do CT scans on these patients, but there's also very good evidence that if you're a smoker and have impaired DLCO but normal FEV1, you're more likely to have disease progression than if you're a smoker with a normal DLCO and normal FEV1. So I think the DLCO maybe have quite an important role here to identify patients at risk of disease progression.
And at this moment, since we are talking about a patient that doesn't have a specific alteration, abnormality on spirometry, but he or she has symptoms, do we have to wait for the abnormalities, or could we start any kind of treatment besides, of course, quit smoking to that kind of patients?
We're doctors, aren't we? Our job is to make our patients better. And all of the tests that we do are there to guide our decision making. They're not to make our decision making. And I was really impressed with the data about the gold 0 patients in COPD gene with SGRQ scores of 36. Now that's pretty bad. So these patients are clearly symptomatic. The only problem is we don't know the best treatment for them. But you know, we have a good armamentarium of bronchodilators and anti-inflammatory drugs. You know, my instinct will be to say, well, if they were principally breathless, I would use bronchodilators, but if they were having exacerbations, and some of them have quite frequent exacerbations, I'd probably use an ICS-LABA. But we don't have the evidence behind that.
Yeah. This patient has a negative impact because they walk less in the 6-minute walk test. And one thing that I think that it's very important for this patient is stop smoking and make exercise.
Yes.
So I think that to point and discuss about the medication with the physicians
Mm-hmm.
and so on.
One of my areas of interest is unreported exacerbations, and there's some evidence now that an unreported exacerbation has the same consequences as a reported one. And so, again, if we see these patients, we need to explain to them about the importance of reporting exacerbations, because they're clearly not just another chest infection. It's not a cold that's gone to my chest. It's telling you there's something wrong with my lungs and I need to have some treatment for it.
Yeah, for sure.
Another issue that has been emphasized so much here is the correlation, the association between COPD and asthma, considering that both are very prevalent and may impact not only in evolution and the clinical course, but also in therapeutic aspects. What's your opinion? Is there any new information about this gray zone?
You mean ACO or ACOS?
Yeah.
ACO without S.
ACO without S, yes. At the ATS there was a great deal of talk and discussion, but very little light. It is clearly, there are clearly patients with asthma and COPD. I actually like the way the Japanese talk about it, and that's asthma in COPD. So it says there are two diseases, not ACOS, which suggests that there is one disease. And clearly we have, all see patients who've definitely got COPD, but clearly have had asthma in the past. And we know in adults asthma doesn't go away, so they've got two diseases. The problem is everybody has their own definition of the clinical characteristics of ACO, and there is no consensus.
Mm-hmm.
And until we have a consensus around that, it's going to be difficult to give general practitioners advice as to how to recognize these patients. When we wrote that chapter, I think, Emilio, you were there?
Yeah.
We wrote that chapter. Our intention wasn't to create a new disease. It was just to help doctors manage patients if they think they've got asthma and COPD. That was all, wasn't it?
Yeah, yes, I think, well, the discussions, I think it's important, because in the past we wouldn't, or at least primary care physicians wouldn't care about chronic airflow limitation as a problem in a patient that could have asthma or COPD. And I think we are in the beginning of this journey to dissect those diseases. If there is only one disease, which I don't think that's the major problem, that we are going to have two diseases. And for respirologists, most of the times, if you use the techniques that we have in our everyday practice, we are able to make sure that, or to be more positive about what is the predominant disease that we need to treat, either asthma or COPD. But I think it's important part of the discussion and more research for future.
Mm-hmm. Well, it is, although we've discussed it's difficult to define ACO, and it's difficult for us to give advice to primary care doctors, the diagnosis or the recognition of the presence of asthma in COPD is very important if you only use bronchodilators for treating COPD, because everybody agrees the treatment for asthma is an inhaled steroid-containing treatment. So recognizing the possibility that a patient has got an asthmatic component to their disease is very important if you just use bronchodilators.
And
I'm sorry. Go ahead.
Besides the history about the patient, is there any specific exam that could we perform in order to select who has asthma or COPD or both, like diffusion or FeNO maybe?
I still think the history of asthma in childhood is the strong predictor for ACO. But as Bernardo is asking, there is something else we could do, try to find out.
Well, Emilio, go.
I think, well, you pointed out history of asthma in childhood. Even though many times in Brazil or in other countries, they don't specify they had asthma, they had bronchitis.
Yeah.
And many bronchitis in childhood are not asthma, but if you have a consistent history about bronchitis in early childhood, that's very important to predict that those patients at least would have asthma associated with COPD. And would you give additional information for the day-to-day practice to start inhaled steroids because of the current moment to use more dual bronchodilation for treating patients with obstructive disease?
Yes, I mean, the point you made is about, both of you, around the clinical history. And of course, patients with ACO tend to have more exacerbations. That's been shown very nicely. So a history of childhood asthma, frequent exacerbations, suggests to me that the patient has got an asthmatic component with their COPD. In terms of tests, well, eosinophils aren't predicted. There was a presentation or data from Nicolas Roche in France very recently showing that it's not a predictor. Bronchodilator responsiveness is not a predictor. Maybe, I don't know, you're an airway eosinophil man. Do you think eosinophils?
I think we have learned that both asthma and COPD are inflammatory disease. And inflammation is the main reason for the symptoms, airflow obstruction, and airway hyperresponsiveness sometimes. They are separated outcomes. But assessing airway inflammation gave us information that at least when they have a specific kind of inflammation that is eosinophilic in the airways, this is using sputum, you are more prone to respond to steroids that if you don't have. However, using sputum examination in day-to-day practice is not feasible in most of the countries. And if you go around several countries, even here in the United States where we are, there are just a few centers that they do this in day-to-day practice. So we have used the correlation with inflammation in the airways, the inflammation in the blood, to see if blood eosinophils would give us information about this. And there was a very good debates about this in a pro and con section yesterday. And I think even though the evidence is not sound enough, as you has pointed out, looking at retrospective analysis, I think they give you insight about how you should manage a patient, and I would like to get the opinion of you regarding this issue.
Well, one other thing around tests is FeNO. You know, again, like eosinophils, FeNO suggests that there may be a steroid responsive component to the disease. In terms of eosinophils, if you were asking me about eosinophils in COPD rather than in asthma, there are a number of retrospective analyses now showing that if patients have exacerbations, those patients with higher eosinophils, let's say greater than 150 per microliter, that inhaled steroids clearly appear to be effective. And nearly every study has shown that to one degree or another. They're all retrospective. For me, I'm waiting for the IMPACT study that will be the first true rigorous prospective test of eosinophils. I suspect that it will not give us a black and white answer, but it will be part of the picture that helps us make the decision.
Because biomarkers are not, most of the biomarkers are not reliable in the clinical practice. That's why we think that eosinophils in the blood are a good biomarker because the patient who has a number of eosinophils, they are reliable according to the time. And this was discussed in some sections in the same time. So there is another study that showed that is old, in this old study, that the patients who has more than 2% of eosinophils and used ICS during his or her treatment, the rate decline of FEV1 was lower than in the other group. So do you think that in the future this could be a biomarker to distinguish two kind of treatment for this patient, according you said to the impact study? Should the impact study answer this question?
Yes, I can't help smiling because Isolde was the study that brought me into COPD. So I'm an old man. Isolde was a last century study, but it had eosinophils and it had rate of decline of FEV1. Unfortunately, in every long-term study that's been done since, eosinophils haven't been measured. So we don't know, but it would be very nice if we do have a simple biomarker that would help us identify patients who are at greater risk of disease progression. Because clearly we would be more inclined to use aggressive treatment to try and reduce the rate of decline in those people who have got a high probability of getting worse. I think the CT scans are taking us in that direction, but there must be other biological biomarkers as well.
Those patients, from time to time, use systemic corticosteroids. And for how long would you recommend to wash out them from the corticosteroids in order to become the result of eosinophil more reliable, since we know that eosinophil, the corticosteroid can lower the level of eosinophils in blood?
I think it's only been studied properly once, but 4 weeks appears to be an adequate period. The effect on blood eosinophils isn't big even then, but I think 4 weeks is long enough for the eosinophils to recover.
Okay.
And in Brazil, we have an idea that the Brazilian patients could have a higher number of eosinophils in their blood. And we saw a poster here that discussed this. What's your impression and immediate impression about this poster?
Well, this is a poster that has taken data from every country that had data about blood eosinophils around the world in a systematic way, and they have compared data from blood eosinophil in different countries. And what we have seen is that regardless the country that we are measuring it, we are going to see more or less the same pattern, and Brazil is inside of this pattern. So it's not different with UK, United States, or Australia. I think that's the important thing that we can get the message there.
Actually, there's a slightly funny story associated with this, because we've done the same analysis in Japan, and the Japanese were, very clean country, very low helminths. They were sure the eosinophils would be lower in Japan than they are in the rest of the world, but they're not.
Yeah.
It's the same across the world. Clearly, in some countries where there is high helminth, it may be, but and the studies are being done, but Brazil is the same as America.
Can we talk a little bit about asthma?
Mm-hmm.
As we know, asthma is also a really important clinical issue. And we know in all world around, asthma is not well controlled. Even though we have a lot of new medications and therapies, are we assessing asthma control or the impact of asthma adequately? We are doing right?
We've known for a long time that doctors don't get it right about assessing asthma control. What's interesting too is that patients don't as well. But if you ask a patient about how bad their asthma is, there was a nice study about their adequacy of asthma control. Nice study done, a big study done in the UK a few years ago, showing that if you ask the patient how well satisfied they are with their control, most were very satisfied. Then if you give them the GINA treatment objectives, they suddenly were much less satisfied. So just relying on the patient's perception is also unreliable as well. Doctors, we know, are very poor at assessing control, but there are very good simple tools to use. You know, whether it's the asthma control test or the ACQ, there are three variants of that. Both of them behave very well. And I used to run an asthma clinic, and I purely do COPD, and no patient came in to see me without having completed an ACT. I used to think I was quite good at assessing asthma, but if I found that the ACT was reliable, and there's very good data showing that ACT scores correspond very well to GINA criteria for control, and it's very quick and simple to do. I would recommend that anybody seeing an asthma patient uses the ACT or the ACQ.
I think for a clinician to have a better perspective for his patients is to assess if the patient is controlled or not. And if you don't measure control, you are not able to tell that the patient is controlled or not. ACT is an excellent tool to use in clinical practice because we are not going to miss any patients that is uncontrolled. So it's very sensitive to find lack of the control, if I would say.
Yeah.
Sometimes in respiratory practice, I have a different opinion. I don't know if you agree or not, but we need a more precise instrument to assess if they are totally controlled, partially controlled, and then you need to use another instrument. But in day-to-day practice, ACT is the best instrument that we can make sure that none of the patients that are leaving our office is uncontrolled of his or her asthma.
I suppose I've got more limited objectives. If we could get 90% of the uncontrolled patients to be well controlled, that would be a tremendous target, wouldn't it?
Yeah.
The complete control is still in the future.
Yeah.
And do you use peak flow or FEV1 to assess control of these patients, or only ACT because it's symptom-based and rescue medicine? I don't know if lung function is very important to evaluate the control.
I can tell something about GINA.
That's right.
If you look at the GINA assessment of current burden, it's basically symptoms that you assess. FEV1, it's considering the future events like exacerbations, the burden of medication, loss of airflow function. So spirometry is something that you need to assess to see if the patient is losing function during the time. To assess the current burden of disease, mostly symptoms, either by the questionnaire that we have at GINA, which are 4 questions, or in the ACT that are 5, and it has the self-assessment of the patient that sometimes is very good. For this, I think it's enough. Spirometry and other peak flow, I don't think that's important in day-to-day practice unless you are thinking about occupational asthma. My opinion.
Emilio, could I ask you your opinion about whether actually emphasizing peak flow, because people like measurements and so on, but and instruments, measurement instruments. Do you think that there may even be a danger in talking too much about the measurements of airflow, distracting attention from measuring control using an instrument like the ACT, that actually talking about peak flow in a primary care setting might actually take their attention away from what they should be doing?
Yes, I think that you are completely right. In the past, there was lots of emphasis about using peak flow. And if you go to real life and see the accuracy of the measurements, and if the patients perform the measurements, there are very good research in Canada showing that after a few weeks, only 40% of the patients would have performed measurements in everyday life, and most of the time you would come with false data. And on the other side, the reliability of those instruments to measure control is very high. And in a way, we are much more precise about diagnosing the level of control of the patient in the situation that we are seeing him.
Another important point that the conference has focused on is about comorbidities. And I'd like to hear from Emilio and from Dr. Paul Jones about specifically comorbidities, the burden of comorbidities in asthma and COPD.
Shall I? Let me start with COPD because there are more comorbidities probably than in asthma, but we're now understanding that there's a lot of comorbidity in asthma as well. It's one of my research interests. One of my, two different people from one's my ex-research fellow, and now a specialist, and one of my research fellows were here. One presenting data about microvascular damage to the brain in COPD, and the other one was presenting evidence about retinal vascular damage in COPD. So we've got those two organs we know have got damage and what appears to be microvascular disease. We're now doing a study looking at the skin and looking at the kidneys, and it may well be that it is a generalized phenomenon of endothelial damage and microvascular disease. Now, what the cause of that is, I don't know. It may simply be a response to cigarette smoke. But there is this big debate going on in COPD as to whether comorbidity are diseases that occur genetically because of, linked to COPD, or they're the result of COPD, or whether in fact COPD is just one part of a systemic disease due to cigarette smoking. It's probably a bit like what we've been talking about in COPD, different phenotypes, but it does appear that vascular damage may be consistent across. If you have damage in one organ, it is likely to occur in another one.
Yeah, I think the bottom line is the injury is not local.
Yeah.
The injury is systemic.
Yes. Yeah.
So we need to consider that, and mainly if you are thinking about COPD that has higher prevalence above 40 years old, and if you do, we see the results of population research, you are going to see that the proportion of patients that have 2, 3, 4, or 5 diseases is very high, and increases with the age. So we certainly need not only to treat the patient with COPD, but we treat the patient.
The patient.
Yeah.
Very interesting.
When I was young, there was a specialty called general medicine. It seems to me that asthma and perhaps COPD is going to require us to go back and be general physicians, able to manage the common chronic diseases that are comorbid in both conditions.
I completely agree with you.
Yeah. Because if a cardiologist diagnoses heart failure, the COPD of this patient will be the comorbidity.
Yes.
If I have a patient with COPD and I diagnose a heart failure, the heart failure is the comorbidities.
Yeah.
So shouldn't we talk about associated disease? That shouldn't this be the preferred name for the associated disease?
Yes.
Better than comorbidities.
They're both inflammatory disease.
Yeah.
Yeah.
Affects different systems.
Yeah.
I agree.
Yeah. Okay. I don't know if more questions. And there's another point that was discussed about, one point about genetics in COPD. There is a shortening in telomere alteration during the genetic exam that was associated with COPD and interstitial lung disease. Did you see this, and what do you think about this association?
It's fascinating, and you know, with also the CT evidence that interstitial disease is present in COPD, it clearly suggests there is a common link there now. And in the COPD gene session, I heard it said with evidence that now 38% of the variants in FEV1 can be attributable to identified genes. A lot of genes, but you know, it is a very significant step forward.
Yeah, very interesting. So I would like to thanks for your participation. And it's a pleasure to be here with all of you. Thank you very much. Então, colegas, chegamos ao final de mais um highlight do ATS 2017. Agradeço a participação de todos vocês. Nós estaremos disponíveis para as perguntas que virão via web, né, para nós discutirmos esses pontos de vista. E vocês poderão também nos acompanhar e avaliar essa apresentação novamente no portal médico da GSK. Muito obrigado.